Welcome. Welcome, friends. Welcome to our 14th webinar. And this welcome is on behalf of the RAC hospitals, the RAC Hospital in Ras Al Khaimah, the UAE, and ARISE, which is the UAE chapter of the UN Disaster Relief Organization located in Dubai. Our topic today is black fungus and COVID-19 infection control. It's more than just black fungus. It is total infectious diseases related to COVID. Now, in March 2021, that's not more than a few months back, globally we had about 136 million COVID cases. And then the second wave struck. Now, one major difference between the first and the second wave was the advent of co-infections and super infections that rode on the back of COVID. And this related to almost 25% of COVID cases, with a high level of almost 90% and above fatality. Globally, pneumonia became very prevalent. And specifically in India, mucormycosis, commonly referred to as the black fungus, prevailed in India, Argentina, and many other tropical countries. Research has indicated that individuals with diabetes and who are immunosuppressed of advanced age are at risk. And the entry of infection is through the nasal cavity and open wounds. It affects the nose, the eyes, and even the brain. Typically located or typically seen by discoloration of the skin. Now, today we have two outstanding speakers. Since mucormycosis or the black fungus impacted India drastically, we thought it appropriate to have our lead speaker from India. And we located Dr. Sunita Reddy, the consultant infection specialist, infectious diseases specialist from Apollo Hospital, who will talk about infection per se, infectious diseases in relation to COVID, and to counter or to support Dr. Sunita Reddy, we have an outstanding speaker, Professor Gottfried Menezes, a professor in our own RAC Medical Health Sciences University, a very highly awarded doctor who will talk about methods of infection control. But before that, we have Dr. Sunita Reddy. As you will see, did her studies in the prestigious CMC Vellore, and then went on to study internal medicine from Oakwood Hospital in Michigan. This followed with a fellowship in infectious diseases from Wayne University, Detroit, Michigan. Dr. Sunita is an American board certified specialist in internal medicine and infectious diseases, with more than 25 years of experience, starting with the Henry Ford Hospital in Wayne State University. Currently, she is the head and consultant infectious diseases in the world-renowned Apollo Hospitals, Hyderabad, India. Dr. Sunitha Na Reddy is a founder member of the Clinical Infectious Diseases Society in India and an active member of the Infectious Diseases Society in her alma mater, the United States. She is part of the core group of the WHO for global drug resistance, or in TB. Ladies and gentlemen, my pleasure and a great honor to present to you Dr. Sunitha Na Reddy.
Thank you, sir, for the warm welcome. It's indeed an honor to be with you today here and share our experience. Yes, as you rightly mentioned, we did have a major problem with mucormycosis in the country, and that really took us by the storm. Fortunately for us, the numbers have drastically come down, both the COVID as well as the mucors, and we are giving a sigh of relief at this point. So with that, going to start the discussion with the case. This is a 72-year-old male with a history of hypertension and steroid-induced diabetes, had received steroids during COVID, as well as hypothyroidism, a non-smoker who had developed severe pneumonia, COVID pneumonia, ARDS, about a year ago. He was treated with remdesivir, methylprednisolone, convalescent plasma, which were the options at that point in time. And he was eventually the steroids were tapered over a period of time. So when he presented it to us a few weeks after this, he had some streaky hemoptysis, though he was otherwise stable. And just to cut short the entire story, eventually we did a PET CT of the lungs, which showed this lesions that you can see in the right upper lobe posterior segment, as you can see as intense uptake here. Okay, so this was a 2.5 centimeter nodular lesion with the central cavitary area that you can see. And apart from that, he had some hypermetabolic soft tissue nodules in the arm and thigh as well. Okay. So a CT guided biopsy of this particular lesion was done. Post-procedure was complicated by a pneumothorax, which was managed conservatively. And there's a high suspicion of mucormycosis because we had a couple of cases like this by this time. And we had started him on liposomal amphotericin B immediately without waiting for the report. And eventually it did turn out to be, this was his histopathological examination, which showed this broad aseptate hyphae. And we actually added posaconazole as well to the amphotericin at this point. And over a course of time, he actually initially worsened before he got better. When about 2 weeks into the treatment, he had multiple other areas that had shown this intense uptake. So we had increased the liposomal amphotericin to 10 mg per kg, and the treatment was complicated by hypokalemia, hyponatremia, hypomagnesemia, mild rise in creatinine, and medically, and eventually for him, the disease decreased, and we were able to eventually, he actually is doing very well right now. Okay, so that's just to tell that mucormycosis, as we typically think about it as a rhino or orbitocerebral disease, can affect other parts of the body, including the lung, is the next common site, and as well as gastric, stomach, which we have seen a few cases as well. So in when we compiled data, this is an older data which now has exceeded over 150 cases at this point. We had majority being the rhino-orbitocerebral mucor, followed by other areas. This is just the initial mucormycosis in the sinuses that we started looking at. But overall, the patients population that we analyzed, majority of them were in the 50 to 70 age group. Again, reflecting the fact that most of the serious COVID infections also come in this age group, and they should be able to survive that. Commonest being the sinonasal, rhino-orbital, and so on. Majority of them being male, and a lot of them with pre-existing diabetes, about a 3/4 of them, and a fair number of them having steroid-induced hyperglycemia apart from the pre-existing diabetes as well. Very little, a few of them were non-diabetics. So in this cohort of patients that we analyzed, we had a reasonable response rate of close to around 70%. A few of them who died, and some of them were lost to follow-up. These patients had received steroids ranging from 650 to 3 gram of steroids cumulative dosage. And most of them actually didn't receive tocilizumab, which is the other drug that was used commonly in those days when they had severe COVID, majority being diabetic. And most of them presented between 3 and 8 weeks after COVID diagnosis. Majority of the patients received liposomal amphotericin monotherapy followed by oral posaconazole. This changed subsequently when we had huge shortage of liposomal amphotericin, and so some of them actually subsequently we used more posaconazole as well. We had to actually use very little liposomal amphotericin for a period of time, and there's absolute no availability of amphotericin. And some of them actually received combination therapy with amphotericin and posaconazole when they were not responding. One of the patients, particularly we use the combination therapy when we have non-resectable disease like pulmonary disease or CNS disease. And when they fail, we have one patient where we used a triple therapy with ampho, posa, and casper as well. We had a few patients that had renal insufficiency, but majority of it was self-limited, and some people did expire. Most of them underwent surgical debridement. With that, I'll move on to the discussion of mucormycosis. Zygomycetes, as you're aware of, are a group of fungi that are widely distributed in nature, often found in association with plants and isolated from plant debris and soil. They're characterized by non-septated hyphae and reproduce asexually by sporangiospores and sexually by zygospores. These are broad, irregularly branched, or have rare septations. In contrast, Aspergillus is narrower, 2 to 5 microns in diameter, exhibit regular branching and have many septations. We have actually had several patients that have had both Aspergillus and zygomycetes in the same tissue as well. Whether it is a co-infection or Aspergillus is a colonizer is something that we debate about. Some of them seem to be actually co-infections because we could see that invasion of both these organisms simultaneously, and both have grown in the cultures also. Okay, just a contrast, these are the septate organisms with acute angle. This is the aseptate obtuse angle ribbon-like hyphae of the mucor. This is the Aspergillus. Okay. If you look at what happened, the mucormycosis over the several decades, the number of cases of mucormycosis has increased by the decade, as you can see here. Predominantly diabetes, but of course other diseases as well, other risk factors that you can see as malignancy is one thing. Organ transplant has definitely taken a toll in terms of the cause for mucormycosis, and IV drug abuse as well. And then subsequently, so suffice to say that the more treatments options that we have, the more complications we see. This is of course not including the COVID patients, but as we now can see, COVID seems to be another risk factor, at least in the Indian subcontinent, for mucormycosis. Commonest sites being pulmonary. Again, this population, as you can see, why are we seeing more non-rhinocerebral here? Though we see quite a bit of rhinocerebral, the risk factors are also different. the solid organ transplant, bone marrow transplant, malignancy. Those are the group of patients where you see more of the other sites being pulmonary, cerebral, GI, and so on. Cutaneous is more commonly in the IV sites or post-road traffic accident trauma. So the cause of the risk factors tell you where the site of infection would be. As was told earlier, the spores are inhaled and deposited in the nasal turbinates and alveolar spaces, which is why these are the common sites of infection. The conidia reach distal alveolar space and germinate, and macrophage phages usually phagocytize the conidia. And this mechanism is impaired by glucocorticoids, which is one major risk factor. Typically, this thought process is if you give more than 2 milligram per kg of methylprednisolone for more than 2 weeks is a risk factor, as you can talk about in the previous population, at least the bone marrow transplant population and the solid organ transplant as well. The once the conidia enter the macrophages, then the neutrophils attack the hyphal forms, and acquisition of the free iron supports the hyphal proliferation as well. This is again impaired by glucocorticoids, hyperglycemia, acidosis, and neutropenia. And then that leads on to angioinvasive growth in the tissue with hemorrhage, thrombosis, and necrosis, and then subsequently leading to dissemination. So as I mentioned earlier, the predisposing condition tells you where the site of infection is. For example, in diabetics, it's rhinocerebral. Malignancy, you see the other sites, pulmonary, cutaneous, stem cell transplants, again, pulmonary, disseminated, solid organ transplant, sinus, cutaneous, pulmonary, everywhere. IV drug use, again, slightly different with more of endocarditis as well, and malnutrition will cause more of a GI disease. Trauma can cause cutaneous or ocular. This is an Indian study which showed the risk factors being diabetes, TB, trauma, neutropenia, and other various different risk factors. Again, diabetes being the most common, followed by diabetic ketoacidosis, and various different organisms that are seen, Rhizopus, Apophysomyces, different species of Rhizopus. These are the common species, and this kind of changes from location to location. In India, Rhizopus is #1 cause. And sensitivity is also slightly different between the species, most of them being susceptible to the newer azoles, the posaconazole, isavuconazole, and amphotericin, not very sensitive to itraconazole. Could not find too much information in UAE because there seems to be a scarcity of data as there in overall, but now they have started a registry, so hopefully we'll get more information from your place as well. So to summarize, majority of the patients pathogen that we see is Rhizopus. Apophysomyces is another common bug that we see. And so these are some of the patient pictures that you can see. This is classic rhino orbital disease, and hopefully we should not be seeing such bad disease. The pulmonary mucormycosis, you can see a halo sign or a reverse halo sign or a nodular disease, as you can see. Yeah, as you can see here. So different form manifestations can be there. It's not always the reverse halo as we talk about in the bone marrow transplant population. Okay. Hyphal morphology, as you can see, the obtuse and the different manifestation looks in the various kinds of staining as well. And moving on to what happens in rhino-orbitocerebral mucormycosis in the era of COVID, the warning signs or these clinical features are nasal stuffiness, foul smell, epistaxis, nasal discharge, nasal mucosal erythema, inflammation, eyelid periocular facial edema, periocular facial discoloration, regional pain in the orbit, paranasal sinus, dental pain, facial pain, worsening headache, proptosis, sudden loss of vision, paresthesias, ptosis, ocular motility restriction, facial palsy, facial fever, altered sensorium, paralysis, and focal seizures. Initially, in the COVID time, this outbreak that we saw, we were seeing a lot of patients that presented to us late. once the government actually started telling that we have this problem and started disseminating the information that these are the manifestations, the presentation became much earlier when patients started presenting much earlier. So the prognosis actually improved uh, after a period of time, because initially the patients were presenting late and subsequently they were actually presenting much earlier. There's a staging mechanism also for the rhino-orbitocerebral mycosis. The stage 1 being involvement of the nasal mucosa, where you have minimal symptoms and signs. Stage 2 being the involvement of paranasal sinus as well, where you can have one sinus or ipsilateral sinuses occasionally going on to bilateral sinuses as well. You can grade them like that. And in these patients, you have to have a nasal endoscopy, MRI, or a CT. MRI is preferred to CT because that seems to be giving us better answers. Stage 3 is the involvement of the orbit as well, where you can have the nasolacrimal duct, medial orbit vision affected, or diffuse orbital involvement, retinal artery, or ophthalmic artery occlusions, thrombosis, or bilateral orbital involvement. Very, very important to have oculoplastic surgeon in to help you out with these patients, because some of them may need exenteration as well. Subsequently, you can have CNS involvement, usually a contiguous. Sometimes we also have seen in this patient population increasing thromboembolic phenomenon and infarcts in the brain, be it MCA infarct, commonest being the MCA infarct. But no, actually not more of not an embolic phenomenon, but infarct, which is probably because of involvement of the cavernous sinus itself and pressure on the blood vessels. So in terms of management, okay, so if you have a suspected case of rhino-orbital cerebral mycosis, then you call them probable. But if you don't, in probable rhino-orbital cerebral mycosis, you have to have, you need to treat these patients as an emergency. You have to get a diagnosis as quickly as possible, and the easiest thing to do is a nasal endoscopy to look at the nasal mucosa and do a fungal stain, which you can do in a couple of, in 1 to 2 hours, you can get a diagnosis. Just the clinical appearance on the nasal endoscopy will tell you if you have a diagnosis. If it looks like, then go ahead with an induction therapy with amphotericin as soon as possible. If for some reason they cannot take amphotericin, your options are posaconazole or isavuconazole. And once you have proven, again, it's easier once your diagnosis is proven, and taking them up for a surgery and debridement is extremely important. For minimal disease, if it is just involving the sinus, you can just do a FES and do a debridement. Sometimes you may need to do maxillectomy as well, depending on the involvement of the sinuses and the maxillary bone. We see a lot of involvement of the maxillary bone and a lot of patients requiring maxillectomy. And fortunately for us, we have not seen too much of need for exenteration, but we had a few patients that needed exenteration as well. Usually, exenteration is more to prevent the spread to the other eye, because by that time you would have had loss of vision and you're not going to salvage the eye. It's more to save the other eye. We also have noticed a lot of patients that have had debridements and subsequently over a few weeks further which is difficult to differentiate whether it is necrosis of the bone because of lack of blood supply, which we are seeing fairly commonly, more so with COVID-associated mucor than what we had seen in the past with regular post mucor in the diabetic patients. We've had to have maxillectomies or removing the bones for these patients, and then we realized that there is no fungus at all seen on these. It is just a necrotic bone because of lack of blood supply. What we are assuming in these patients is that COVID, as we know, causes thrombosis. And probably there is more thrombosis in the blood vessels in these patients, and there's lack of blood supply with the combination of COVID affecting the blood vessels, as well as when you're debriding them, some of the blood supply goes down, and so these bones are getting necrosed over a period of time. And this becomes a challenge because you cannot differentiate, is this osteomyelitis from this fungus, which we are seeing from time to time, and as well as necrosis of the bone itself. So we have to remove the bone, send it to pathology for us to actually tell us what this thing is. So what do you do to prevent rhino-orbital mucormycosis? You need to use judicious and supervised use of systemic steroids, along with careful monitoring of the blood sugars. Very, very important. And also, it's not that all of the patients have high blood sugars or have used steroids. We have had a fair number of patients that have not been diabetic or used steroids and still get mucormycosis. So there seems to be more than just steroids and diabetes. COVID itself seems to be playing a role. In fact, our treatment strategies, when we see these particular patients, we don't need to be as aggressive in some of these patients, and they seem to be getting better. A little bit of surgery and a shorter duration of antifungals seem to be taking care of the problem in certain group of patients. We are assuming that because that is probably because the immunosuppression related to COVID is resolved, and that's why they're getting better. Again, all of these are thought process that we have, which we are not able to prove as yet. So other precautions that you can take, they talked about sterile water for the humidifier, which has not been proved. Again, personal and environmental hygiene, which is easier said than done. Betadine, mouth gargling, not sure how much of this will help. Barrier mask, which is always being used, and these patients are still developing this problem. If you're using if your patients are sick for a longer period of time and on steroids for a long period of time, there is a thought whether posaconazole prophylaxis will help these patients. But again, we need to have more studies on that. Treatment modalities. When you suspect mucor, you need to first establish diagnosis as quickly as possible and start the treatment as quickly as possible. Unfortunately for us, there are no randomized controlled trials in this patient population. It's more of a experience that is teaching us. We have some observational data and case series and case reports. So what are the guidelines say? These are the European guidelines for mucormycosis. First of all, most important is you need to have a multidisciplinary approach, and liposomal amphotericin B is your drug of choice. Standard doses of 5 milligram per kilogram, and if you have to, if it's a CNS disease, you need to give much higher dose. You need to monitor renal function. Lipid complex and colloidal dispersion also can be used if this liposomal is not available. And deoxycholate is not favored. First choice is liposomal and followed by lipid complex. Deoxycholate is not favored primarily because of the toxicity, and also not favored in CNS disease because liposomal probably has a better penetration to the CNS. Posaconazole, there's no data as far as first-line treatment is concerned. There is data in terms of salvage treatment, which we'll go in a little while. Combination therapy is also an option. We'll talk about the studies behind that in a little while. Okay. For salvage and maintenance therapy, again, there is data with posaconazole as well as combination therapy with ampho and posaconazole. Maintenance therapy, posaconazole, again, more of not a randomized control trial, but more of an experience that we know that it seems to be working. Okay. So individual drugs, liposomal amphotericin B, it's 3.5 to 10 mg per kg. Typically, we start with 5 mg per kg and go up if required. And step-down therapies with posaconazole. We usually give amphotericin for average about 4 weeks normally. But if thanks to the non-availability of amphotericin, we actually had to come down on the duration of amphotericin to 2 weeks. Majority of the patients did respond well. A few patients had relapse, and so we had to go back to amphotericin. A typical step-down therapy is posaconazole for as long as it is required. Isavuconazole is an alternative. There is limited data, but seems to be promising. And of course, very important is the elimination of predisposing factors for infections such as hyperglycemia, metabolic acidosis, immunosuppressive drugs, and neutropenia is also very critical. So, to summarize the recommendations, when you suspect, you need to have a radioclinical presentation, radiology, and look at what the risk factors of diabetes, malignancy, solid organ transplant, trauma in general. In our case, COVID at this point. Diagnostic options, we can do PCR. We have started doing mucorales PCR as well in certain patients, particularly on the tissue, and the results seem to be promising. There have been a few cases where we're not able to see the bug itself, but the PCR has come positive. And consistency, when we have seen the culture growth or the PCR pathological diagnosis, we have been able to diagnose with PCR. We are doing a multiplex PCR with a few different kinds of fungi, and that will help us identify what kind of mucor we are seeing as well. Again, treatment is emergency treatment, surgery, and antifungals. Typically, liposomal amphotericin, isavuconazole, or posaconazole if you're not able to tolerate. When to step down treatment is based on radioclinical stabilization. We hardly ever use PCR for that purpose at this point. So step down is basically isavuconazole or posaconazole. So just a little bit of, we'll go through a few studies in the next couple of minutes before we stop it. High dose amphotericin of 10 mg per kg has been tried in patients with CNS disease and seems to have a good response, but complicated by transient rise in creatinine. Nephrotoxicity is a known concern, particularly more with amphotericin deoxycholate as compared with liposomal. As you can see, 15 versus 33% between the two drugs. Isavuconazole, there is data with isavuconazole. A small number of patients, about 35 patients in the study, that have used isavuconazole, and it was similar to amphotericin B. So isavuconazole was non-inferior to amphotericin in the treatment of rare fungi, including mucormycosis. Comparing isavuconazole and posaconazole, isavuconazole is posaconazole, we have both the suspension and the tablet formulation. Suspension was a challenge in terms of administering because you need to have a high fat diet, and these patients usually are having troubles eating in the first place, and the bioavailability is very erratic. So now we moved away from the suspension and going only with the tablet formulation, where your bioavailability is much better, particularly when you take it with food. Isavuconazole, it's very reliable in terms of bioavailability, irrespective of whether you have it with food or without food. And so that's a great advantage with isavuconazole as compared to posaconazole. Very reliable drug. Combination treatment, what do we know about it? Combination of polyenes and caspofungin seems to have have a success rate. As you can see, monotherapy doing not so well, whereas with the combination, a much better response. Why does it work? The possible mechanisms are disruption of the beta glucan cross-linking of the cell wall by the echinocandins, and that can lead to enhanced delivery of the amphotericin into the cell membrane, altered virulence of the fungus, either by stunting filamentation or altering the cell wall content, and enhanced host response to the fungus. The limitations of this particular study is the retrospective study with historical controls. Combination of posaconazole also has had good with the 50% favorable response as a salvage therapy when most of them had failed monotherapy in this group of patients that have had hematological malignancy. The recommendation by the European guidelines for CNS mucor is amphotericin, liposomal amphotericin, a higher dose of 10 mg per kg. And I'm going to skip some of these slides. And prognosis is generally okay when you're talking about sinus disease, but when you're talking about cerebral disease, Once the brain is involved, the prognosis is poor, with the mortality approaching about 60%. Pulmonary disease again has a high mortality, and disseminated disease also has a high mortality, which is the reason in some of my cohort patients we have used combination therapy and had a little bit reasonably good success rate, I would think. Adjunctive therapies that have been considered: reversal of immunosuppression of whatever immunosuppressive drugs that we had, reversing the neutropenia if you have neutropenia, tapering the steroids, hyperbaric oxygen. Other things that have been tried are granulocyte stimulating factors, statins, and combinations of interferon gamma and nivolumab, which is monoclonal antibody. These are all very limited data on these things. Okay, there are other newer antifungal drugs in the horizon, so hopefully we'll have more options. With that, to summarize, liposomal amphotericin is your mainstay of treatment. Your other options being posaconazole and isavuconazole. If there's a cost issue, we do use deoxycholate formulation. Echinocandins only in salvage treatment. And duration of treatment is until complete clinical and radiological resolution. Okay, thank you.
Dr. Sunitha, thank you ever so much for that enlightening and informative talk regarding the causes, the effect, and the treatment of black fungus. Your last few slides indicated that the mortality rate was high in this particular malady. And I'm sure our medical doctors would have found your talk so interesting in terms of the numbers of research that you have presented and the various medical options. Thank you so much for your talk. We could not have chosen a better speaker to talk on this subject than the consultant infectious diseases from the prestigious Apollo Hospitals group. Thank you. Now, while Dr. Sunitha has spoken about the effect and treatment of black fungus and infectious diseases relating to COVID, our second speaker will touch upon infection control. And it is my pleasure to introduce from our university next door, the RAC Medical Health and Sciences University, the chair of the Infection Prevent and Control Committee, Dr. Gottfried Menezes, to talk about infection control. Now, Dr. Gottfried Menezes has an illustrious career. I noticed that he has done his PhD studies in medical microbiology from JIPMER, which is in India. He's a life member. He is also qualified. He's done his PhD, medical microbiology and immunology is what he teaches. And he is also a clinical microbiologist in our very own RAC hospital. Now, he is a life member of the Indian Association of Microbiologists and a member of the Emirates Society of Clinical Microbiology, as well as the International Association of Medical and Microbiological Research. In addition, he has over 20 years of professional experience working in several reputed organizations around the world. Erasmus MC in the Netherlands, the Hague University in Saudi Arabia, where he was an assistant professor and scientist. He also worked in the renowned Institute of Science. A true professor, he has more than 50 research publications in reputed journals and more than 1,000 citations. He's a member of the editorial board of several prestigious journals. He has won several awards and grants from the Kingdom of Saudi Arabia for his research, and also from the government of India, where he traveled to China and Thailand for various research projects. Ladies and gentlemen, my pleasure to present to you Dr. Gottfried Menezes.
Good morning, everyone. And thank you, Professor Adrian, for that warm introduction. I'm grateful to the administration of RAC Hospital, Professor Adrian, and Dr. Wilku for this opportunity. And it's my privilege to be a co-speaker along with the renowned ID specialist, Dr. Sunita. And since there is a mixed audience along with healthcare professionals, there are people from community, there are students as well. So I'll try to strike a balance in my presentation with the overview on COVID, as well as co-infections and infection prevention and control mainly. So I'm Gottfried Menezes. Enough of introduction has been given. I have no relevant financial or personal disclosures to this presentation, and it calls for all of us to be a leader in keeping ourselves, our workplace, study place, family, and community healthy. So the pandemic is not over yet. And what are the 5 reasons to keep our guard not down yet? And looking at the global situation, not enough people have been vaccinated yet, and most children won't get vaccinated for a while. Newer variants of the coronavirus are still spreading, and we have observed that there is loosening of pandemic restrictions worldwide, and people are starting to travel again. So the main objective of infection prevention and control to provide clear and actionable guidance for safe operations through the prevention, early detection, and control of COVID-19. My presentation would include few questions to begin with: introduction, pathogenesis, immunity and diagnosis, co-infections and secondary infections, overview of them, and mainly the prevention and control aspect, and to end with take-home message. How long does immunity to COVID-19 last? That's the main question to begin with. Which statement do you agree with most about COVID-19? The immune response is either entirely beneficial or is it harmful? And is viral load connected to levels of immunity? Do you think you could be infected twice or thrice? I guess we have come across cases recently who's got infected even 3rd time in spite of being vaccinated. Could there be any cross immunity with the cellular immune response from other coronaviruses? And what do we need to achieve herd immunity, and is it possible? And is COVID-19 a droplet-borne or an airborne precaution or an infection? Which are the suggested disinfectants for SARS-CoV-2? And if a fabric mask can be used, what should be the quality of the fabric mask? And what are aerosol generating procedures when it comes to the hospital setup? And what is the doffing and doffing of PPE? How frequent are co-infections or secondary infections when we talk about COVID-19? And are these infections associated with poor outcomes or severe COVID-19 disease? Yeah, finally, starting with the introduction, we have come across coronaviruses like SARS and MERS. In 2002, we saw that SARS coronavirus, did not have too many cases or deaths due to low transmission, whereas SARS-CoV-2, because of high transmission and being able to shed even when asymptomatic, led to this pandemic. And we are aware that ACE2 is the host receptor. Viral spike protein interacts with this receptor and gains access into the human cells. Coming to involvement of different organs, how it manages to target different organs. So ACE2 is not only present in the respiratory tract, the receptor, it is present in various organs. So this broad expression of ACE2 is responsible for multi-organ injury observed with COVID-19. Yeah, so it's an animal pathogen being transmitted to humans, and animal pathogens are usually known to mutate. They keep mutating, and that's the reason for presentation, disease duration, and immune response not being classical. It keeps changing. The symptoms have been varying over the time, mainly because of mutations. Yeah, we are aware of many facts. The good news is the main fact about around 80% recover from the disease without needing special treatment still holds good. And the numbers have been ever increasing. The pandemic is not over yet. And these are the top 10 countries with the highest total number of cases, which hasn't been changing much. So 80%, around 80% remain mild, whereas 5% fall critically ill, requiring mechanical ventilation, undergoing shock, multiple organ failure, and of course, requiring ICU admissions. Innate immunity is delayed and dysregulated, and that seems to be the issue with the innate immunity. Adaptive immune response among the T cells, cytotoxic T cell manages to kill the cells infected with the virus, whereas helper T cells, they manage to stimulate the B cells, which is a very crucial step in the humoral immunity. Among the antibodies, IgM is the first antibody to be produced, followed by IgG. So here, the most important aspect is the quality of the antibodies, not the quantity of the antibodies. So they need to be neutralizing antibodies. That's what is crucial there. And the levels of neutralizing antibodies. Yes. So too much of something good could be bad. Neutralizing bodies are definitely helpful, but then in severely infected subjects, it's been noticed that there is a very high level of neutralizing antibodies, which could be damaging. And we should be aware that most antibody tests cannot differentiate between neutralizing versus non-neutralizing antibodies. As I said, the symptoms have been varying over the time. Of late, the most common symptom happens to be loss of smell and loss of taste, suggestive of CNS involvement. The antibodies to be produced are against the spike proteins and nucleic acid protein of the virus. When you detect IgG alone, it is suggestive of previous infection, whereas if you have it along with IgM or IgM alone, it could reveal active infection, which helps only in screening and not any kind of definitive diagnosis. We do have different diagnostic methods. The next generation sequencing, NGS, does help, though it's not economical, does help giving us an idea about the mutants in circulation. Regarding the different markers, lymphocytopenia, enzymes like ALT, AST, CK, and D-dimer are quite helpful, but we should remember that a patient need not have all these values to be considered infected. So that's the reason why we do battery of tests and not just one or two tests in admitted subject. Viral load in the nasopharynx is maintained in serious disease subjects. So that makes it clear that nasopharyngeal swab is still a good sample. It's a very good sample. Coming to gender dominance in the disease, it is men who dominate in case of severity of the disease, mainly because of more inflammatory cytokine response compared to women. What makes us different or vary in immune response to COVID-19 is because of transcriptional and epigenetic processes which vary between individuals. So among the antibodies, it is the secretory IgA which plays the role, important role, critical role in protecting individuals against SARS-CoV-2, particularly when they are neutralizing antibodies. Yeah, so cytokine storm, we have been hearing about it, and that's what creates most of the issues. It is a dysregulated, exaggerated production of pro-inflammatory cytokines, which leads to excessive accumulation of inflammatory cells, pulmonary edema, and eventually lung damage and airway occlusion, potentially resulting in death. Yeah, so it's been quite intriguing when we heard about the treatment aspect, antibacterial being used, antiparasitic being used. It was all because of some sort of beneficial properties of these agents. And we also heard about vitamin C, vitamin D3, and zinc. These are mainly used because of their dampening effects on the cytokine storm. Okay, they are important. We know that vitamin C is an immune booster. So these in combination could help in dampening the effect of cytokine storm. Yes. Later on, we also heard about terminology, variants of concern and variants of interest. So variants of concern, among them, the most important one was Delta Plus. These variants of concern are considered to be fitter than the original strains of the virus, whereas variants of interest still under study, or you could say these could become variants of concern in the future. They may start, prolonging the pandemic, which it doesn't happen. Yes. And there is a term called as long COVID-19, long COVID-19. We just 2 days ago, 3 days ago, we saw in the newspaper, in Khaleej Times, about long COVID-19, and also it's there in the DHA website. Yeah, so what is long COVID-19? When after recovery, if the symptoms persist beyond 4 weeks, 4 weeks is the least, but it can prolong for months to a year. There are subjects now we know that they have symptoms prolonging, to months to years, months to a year almost. Yeah, so this is mainly because of either CNS involvement, reflecting accordingly. And we have seen that subjects who have completed the dose, it halves the chance of developing into long COVID. So it's very important that we complete the dose of vaccine. Yeah. After recovery, we have also seen that it's not a reinfection, but people still remain positive, mainly because of replicating SARS-CoV-2. Here, in terms of RT-PCR, it may not be considered positive because the CT value may be 35 and above, but the person may be still infectious if he has enough viral load. We are aware that during viral infections, co-infections and second infections are quite common. That's the reason why, depending on suggestive symptoms, we go for antibiotics. And these infections happen to worsen the pathogenesis of SARS-CoV-2, and it is challenging to diagnose these infections mainly because of healthcare exposure issues and aerosol generating procedures. And when it comes to co-infections in general, it is particularly with other seasonal respiratory viruses. We are aware of influenza and metapneumovirus. All these are seasonal respiratory viruses. There's a long list of co-infection causing microbes. These are viral They could be different, bacterial and fungal, mainly where the infection starts from the respiratory tract as well as other means. So these co-infections are mostly seen in hospitalized, severely ill COVID-19 patients. And among the causative agents, there is 10 times more chance of bacterial, fungal secondary infections compared to viral. Whereas in secondary infections, it could be, yes, the secondary infections are mainly because of bacterial and fungal, whereas the co-infections could be more of viral. And we have also seen that there has been extensive or excessive use of antibiotics, leading to rise of multi-drug resistant gram-negative strains in the hospital environment, leading to these infections, secondary infections in the subject after discharge. Yeah, so these references makes it very clear that infections due to gram-negative were multi-drug resistant. We see the word ESBL, extended spectrum beta-lactamase producing, which limit the therapeutic options and forces to go for carbapenems or other combination antibiotics. Yeah. COVID-19 associated mucormycosis. In healthy individuals, we know that when the spores are inhaled, it is contained by the innate immunity, whereas in immunosuppressed subjects or a person with COVID-19 or uncontrolled diabetes, all these makes it a potential pathogen. So the receptors are GRP78 in the host, which interacts with the coat protein called as coat H3 of Mucorales order. These are the group of fungi. And steroids used in the treatment of COVID-19, that itself is responsible for hyperglycemia and immunosuppression, giving a golden opportunity for these fungi to prolong the infection, to proceed with the infection. So these group of fungi are angioinvasive, thermotolerant, and saprophytic. The best example is Rhizopus arizus. We do also have mucor species at times. And we know that the mucormycosis was 70 times higher in India than that in global data. It was 70 times higher. I'll come back to the reason being 70 times higher in India. It's not only the immunosuppressed, mainly it was the uncontrolled diabetes and immunosuppressed individuals who suffered from mucormycosis, but there was also incidence of immunocompetent hosts, individuals suffering from mucormycosis. Among the mucormycosis, as Dr. Sunita said, the most common one is ROCM, rhinoorbital cerebral mucormycosis, followed by pulmonary and cutaneous. And these spores are present everywhere. They are ubiquitous. Yeah, so the reason for 70 times higher rate of mucormycosis in India is mainly because of favorable weather conditions, tropical and humid weather, which favors the fungal growth on fruits, vegetables. You can see that there's a jackfruit bud covered with the spores, covered with the growth and spores of Mucorales order of fungi. So this makes the spores, being present in a large number in the air, so which when inhaled, if it's immunosuppressed individuals or COVID subjects or uncontrolled diabetes subjects, it leads to mucormycosis. It's not just diabetic individuals. It's quite depressing to hear where, if it's somebody is diabetic, it may be depressing for him to hear about it. So it is uncontrolled diabetes, not diabetic alone. So we could have, in-house methods to clean our vegetables and fruits, which are quite effective methods. I'm sure there are a lot of community members listening. So it's not preferable to use detergents to wash fruits and vegetables because it can get through the pores on the skin, though we skin out later on. So it's preferable to use solution like salt, turmeric plus vinegar, equal proportion of them. First wash under running water, then soak in this solution for 30 minutes, and then again rinse it with the running normal water, and dry and store. If you're storing, you make sure that you dry it out and store. Yes. So it had reached epidemic proportion, ROCM, and it is the steroids steroids and uncontrolled diabetes is the most important predisposing factor. And we know that the mortality reached up to 90% among the people who suffered from mucormycosis, mainly with the cerebral involvement. Coming to the main aspect, that is COVID-19, primarily transmitted through droplet transmission when you are in close proximity, say 1 meter or less to a subject, or it could be contact transmission because of directly coming in contact with the COVID subject, or through fomites, inanimate objects, or it could be airborne transmission, mainly in the hospital setup where we have aerosol generating procedures. So IPC helps us in protecting ourselves, our patients, and protecting family, community, and environment. So that is the main objective. The IPC strategies are for standard precautions, early recognition, source control, and empiric additional precautions for suspected cases. Yeah, so standard precaution says that we're supposed to consider every subject as potentially infectious, every subject in the community, every subject in the hospital as potentially infectious, so that we follow precautions. And the healthcare personnel cannot take the WHO 5 moments of hand hygiene for granted. It has to be always followed. So hand remains to be the key link in the chain of transmission. We should scrub all surfaces of the hands at least for 20 seconds, following the 8 steps of hand hygiene by the WHO, which altogether may take 30 seconds. And whenever your hand is visibly dirty or contaminated, always go for soap and running water. And if you're using hand sanitizers, make sure you follow precautions because it is flammable. Wash your hands often, especially before and after eating, after blowing your nose, coughing, sneezing, and after visiting the washrooms. Yeah, respiratory etiquettes. Always, if you do not have tissue readily available, you sneeze or cough into your bent elbow, and make sure that you dispose these tissues immediately. Do not leave around. General principles of personal protective equipment. We should perform hand hygiene before and after. This has to be followed always. And if there is damage in any one of the PPE, make sure that you remove and replace. And the moment you're done with the patient care, make sure that you remove all PPE as soon as possible. Donning and doffing of PPE is quite cumbersome, but we have no options. We have to follow very cautiously, and we should train ourselves. And if there are doubts, we should always ask and follow them accordingly. The mask is meant to cover mouth and nose. We are aware about it, but still sometimes we expose our nose and we do not follow the mandatory guidelines. And do not reuse single-use mask. Preferably use the single-use mask only for half a day and then change in the afternoon. And single-use mask should be disposed immediately upon removal. We should not leave them around. Coming to healthcare professionals, to prevent transmission of infection to family members, we should avoid carrying too many place like wallets and pouches. Whatever is required, mandatory to be carried along with you, carry it in a Ziploc, and leave things which are not required to be carried back home. Thoroughly wash hands, forearms, and elbow, not just the palm of the hand. And hygiene to be followed. Forearms and elbow has to be washed thoroughly before leaving the workplace. And upon reaching home, first thing to be done is visit the washroom, bathe yourself and change your clothes. Regarding the level of care for PPE, it depends on the um, the situation. For example, if there is a suspected or confirmed case of COVID-19 requiring healthcare facility admission with the aerosol generating procedure, then what do you need? You need hand hygiene, a gown, respirator, a goggle, and yeah. So you should make sure that if you're wearing N95, you do not wear the surgical mask. It's not like surgical mask followed by N95. That may interfere with the protection. So make sure that you use N95 along with other PPE in case of aerosol generating procedures. Yeah, so besides wearing mask, it's very important that we follow the social distancing, which is at least 1 meter distance or according to the local guidelines, and make sure that you wash your hands frequently and thoroughly even while wearing a mask. Yes. Coming to surgical mask versus the fabric or cloth mask, among elderly and subjects with underlying conditions, it's better that they wear surgical or disposable mask. And any mask you wear should be snugly fitting. And when it comes to fabric mask, it should be breathable fabric, preferably made of cotton, and it should be a tightly woven fabric. That means if you see through, you should not be able to see the light. Mask with 2 or 3 layers, and or it could be mask with inner filter pockets. So these are all recommended. And if you're using a cloth mask, make sure that it is washed every 24 hours, or at least after 24 hours, you make sure that you wash it. And then definitely you're going to have more than one, so you're going to reuse later. But you should not continue using the same fabric mask for more than a day. That would minimize the effectiveness of the mask. So UAE ministry has come out with the exemptions of wearing mask, and that seems to be quite sensible, and people will not be apprehensive that whether I'm following it right or wrong. So others who are exempted are children under 6, but then children above 2 years can wear, provided they do not have any breathing difficulty, do not have other chronic diseases, and they're able to remove the mask when required. Disabled people are also exempted, and other severe respiratory issue subjects. Regarding cleaning and disinfection, we are aware that on certain surfaces like steel and plastic, virus can survive for even 96 hours, whereas on surface like copper, which seems to be antimicrobial, we are aware that copper is antimicrobial, it survives only for 4 hours. When you're wearing N95 mask, as I said, do not wear surgical masks. Along with that, you should not wear a surgical mask followed by N95. You should be N95 alone so that it is effective. What you could do is you can do either positive seal check or negative seal check. In positive seal check, you exhale sharply and look for a positive pressure inside the respirator. Whereas in negative seal check, you inhale deeply and look for negative pressure. Yeah. Take-home message: co-infections and secondary infections vary based on geographical regions. They do not remain same all over the world. Co-infection seems to be higher among pediatric patients, and secondary infections are higher among sicker patients who are hospitalized and who require extended hospital stays. To begin with, we saw that the infection was not common among children, but over the time, the mutant made it possible, and children did get infected, and up to 6% of pediatric cases of COVID turn severe or critical. Safety is the key for containment. There are no options. We have to follow them. The key principle happens to be hand hygiene, respiratory etiquette, and social distance. We have to follow standard and additional precautions to protect ourselves and community in case of hospital, healthcare professionals, and PPE has to be used judiciously, and it has to be used appropriately. And we should pay attention to donning and doffing, wearing and removing them. It's always preferable to stay home when sick, even if it's just a seasonal flu. It's always preferable that we stay home while sick, either to protect ourselves or to protect others. And a balanced diet and healthy lifestyle can help you in good microbiome. Being a microbiologist, we always talk about good microbiome. That is, we do have a collection of microbes in our gut, and it is either good or bad. So what do we need to have a good collection of microbes in terms of microbiome? There has to be balanced diet, healthy lifestyle, exercise at least 1 hour per day, and completing vaccination, nationwide or globally. If more and more of vaccination is done, this could help in herd immunity. And since the future months are going to be pleasant and cool enough, we could always open the windows and ventilate the rooms, which is not possible in the hospital environment, but otherwise it is possible. So I leave you with the beautiful pictures of Russell Khaimah. It's COVID-19 is a war on the face of common enemy, and hats off to all the frontline healthcare workers. Thank you.
Professor Godfred Menezes, that was nothing short of brilliant. Thank you so much. It was so informative. It gave us individuals who are not as knowledgeable as we should be, all the information that we required in order to understand COVID and also protect ourselves from it. Thank you so much for the vast information that you gave us. However, there was one point which caught my attention in a most frightening way. It was only this morning that I normally eat fruit for breakfast, and this morning I ate a mango from India. Now, Dr. Godfred, you and Dr. Sunita, I'm glad I can see both of you on the screen, and I'm glad that you are listening in. When I saw Dr. Godfred's PPT of the raw fruit on the screen, I noticed that the apple had something black on the skin, on the surface. Now, normally I would not have paid much attention to it, except that this morning, that mango that I ate had black coloring on the skin. It was a mango. I was interested to eat it, and therefore I took a knife and cut that particular portion out and ate the mango. However, even while I am double vaccinated, regretfully, I am above the age of 70. So what am I going to do? I am going to save Dr. Godfred's number. I am going to save Dr. Sunita's number, and I will definitely contact you in case I need to. That little black piece on that mango, which I cut out, I really should not have eaten the mango, I would imagine. But nevertheless, what can I say? Like Dr. Godfred says, consider all people at risk all the time. Thank you so much for that presentation, Dr. Godfred. Dr. Sunita, thank you so much for the presentation. It was so on how to manage mucormycosis. And Dr. Godfred, your information was enlightening for those of us who are not medical professionals. I now leave you in the capable hands of my colleague, Dr. Wilku, who will ask a few questions.
Thank you, Professor Kennedy. I'll be very happy to put on forward some questions we have received in mail and during the chat also. It was really a wonderful session from both of the speakers, Dr. Sunita and Dr. Gottfried. It was really enlightening. First question comes from, anyhow, the answer has been already given, but there is a little connected part on it. Mr. Bharat has asked, does black fungus cause eye damage? And what are the signs we should look for black fungus if the person is affected with COVID and is on home quarantine? Because the patient is not in the hospital and he is in quarantine. So what are the signs and symptoms we should be looking for, whether it is a black fungus or something like that? Dr. Sunita, I think best answer you can give it.
First of all, black fungus is a misnomer. It is not necessarily black. The necrosis, the skin damage that you see looks black, so kind of the name got stuck to it. The fungus is not black, so you don't have to worry about anything that looks black. In terms of the symptoms, typically if you have mucor after COVID, it develops a few weeks after the disease. Very rarely have we seen mucor develop while the patient is still in the quarantine period. But if you do develop symptoms of sinusitis, typically sinusitis, which is facial pain, watering of the eyes, foul smelling discharge, then you would need an ENT doctor to evaluate you to see if there is sinusitis. Again, remember, sinusitis is much common problem and can happen after a viral infection. Most likely, sinusitis is the most common problem even in this case. But an ENT doctor has to look into the sinuses and understand if it's just regular sinusitis or if you're looking at mucor. We did see a flurry of referrals to the ENT department when the concern for mucor came in. Most of the time, we just needed to reassure people that, see, this is just a regular sinusitis. Don't worry too much.
Yeah, thank you, ma'am. There is one more interesting question. Mr. Harsahad is asking, his grandfather is diabetic and had COVID infection. After recovering, he noticed that his left eye is not closing properly. Means he's telling about the drooping of the eyelids. Is it due to black fungus?
See, drooping of the eyelids tells you that you have a facial nerve palsy. So that can happen by diabetes itself. Diabetes can cause cranial nerve palsy and can do that. Yeah, of course, fungus, mucormycosis that affects the eye can cause a lot of problems, including swelling of the eye, proptosis, which means the eye just literally pops out, along with the sinuses problem. So the best way to differentiate it is by having your doctor evaluate you.
Yeah, thank you, ma'am. There is one more interesting question. I would rather request both of you, Dr. Sunita and Dr. Gottfried, to put on your views on it. During the presentation, Dr. Gottfried was talking about ROCM and the secondary infections. One minute, please. Yeah. So, Mr. Mohan has asked, secondary infections can be blamed on inappropriate administration of steroid or immunosuppressive drugs during COVID. How to use them religiously, and any specific guideline for keeping glucose level down by diet control during infection and post-COVID. This is a combination of both the things. One side, Mr. Mohan is asking whether there is a guideline of using a steroid. That I would say the doctors are the person to make a guideline. Definitely about keeping glucose levels by diet and other things. Both the answers can be given by Dr. Sunita and Dr. Gottfried. First, Dr. Sunita, you can answer, please.
So there are two questions here. One is how do you control blood sugars? Blood sugar control in COVID is a little bit of a challenge primarily because COVID also affects the pancreas, and since pancreas is responsible for diabetes control, that can get very challenging. Very important, and any infections can cause hyperglycemia, that's increased blood sugars. So that also is a challenge. So when you have two components causing your blood sugars to go up, it is a challenge. So for important thing is to keep tab of what the blood sugars are. If so, careful monitoring of the blood sugars, and based on that, your doctor will advise you if you need to control your diet, you need to take oral medications, you need to take insulin. Very often, insulin is given in patients with COVID, irrespective of the steroids, because the sugars do develop much higher. So again, you need to monitor yourself and consult your doctor on that. The other question is how to dose steroids. The most authorities recommend dexamethasone 6 milligram or its equivalent for moderate hypoxia in COVID. But in severe cases, this dose can go up much higher depending on the need. Again, as soon as you see that response, rapid tapering of the steroids is very essential. Steroids are a double-edged sword. They are very useful in life-threatening conditions like we have in this situation. And so you use it for the shortest duration possible and the lowest dose required at that point in time. Careful monitoring of the sugars is very important again when you're giving steroids, because that can also increase your sugar levels. And screening for secondary infections when you see a change in clinical status, be it being new fever, worsening respiratory status. These are the two commonest things that we see in our patient population with COVID: fever and worsening respiratory status. Then we have to reassess at that point.
Yeah, thank you, ma'am. Dr. Gottfried, you can put your views.
Yeah. Yeah. As Mr. Mohan says, when we are not aware, it is possible to doubt the line of treatment. In case of ICU admitted and severe COVID-19 subject, it is about saving the life, which is crucial, since it's fatal process. So it's not about adverse reactions or antibiotics turning antibiotic resistant microbes in the hospital environment. All this is minor issues. So the main aspect is saving the subject at that moment. And to begin with, maybe there were no fixed guidelines about corticosteroid use, but then over the time, there was fixed guidelines and policies brought out by the concerned policy makers.
Yeah, thank you. I think most of the questions what we have received has been answered during both the presentations, and definitely there is a short of time. If any question is being unanswered, which is not here, we have received in the mail, we will reply to that question definitely. Thank you so much, Professor Kennedy. Over to you.
Thank you so much, Dr. Wilku. Thank you so much. And a special thank you to our esteemed speakers, Dr. Sunita and Professor Gottfried. Thank you so much. As usual, a thank you to our audience. Now, today we had 180 plus registrations, which is probably the highest we have had before. We have consistently hit above 100 registrations for our webinar, but today's 180 plus is probably a new record. I'm sorry, my colleagues have corrected me. It is 205, and that is probably a new record. And I might also tell you that we are talking to audiences not only in the Middle East and India, Pakistan, Afghanistan, and locations in Southeast Asia. We also have an audience in Europe and from the United States. And we have our esteemed speakers to thank for this. I'd like to thank also my colleagues who have helped us to put together these 14 webinars. We've had 28 brilliant speakers. All the information that is provided during the webinar is immediately uploaded onto our website and available for our audience to look at it anytime they choose. So you can see the recording over here. We also take great pleasure in making an appropriate editorial version of clipping off the unnecessary spaces, and we send it as a memento to our speakers. Ladies and gentlemen, friends, colleagues, my esteemed speakers, and my beloved audience, thank you so much for participating in our webinar today. And we look forward to seeing you 2 weeks from now for another very interesting topic. Thank you so much and good day.
Thank you all.